So the first test I'll be performing is the Laslet cluster of tests done if there's suspected SI joint pain. So I'll perform 4 tests, and if 2 out of the 4 tests are positive, then we can rule in the SI joint. So first I'll do gapping. So I'm going to the patient's ASIS and pushing out, looking for a reproduction of the patient's complaints and pain, which would indicate a positive test. So next I'll perform the thigh thrust, getting my hand under the patient's sacrum and providing a quick thrust as so, creating pressure at the SI joint, and then a positive test is reproduction of his symptoms. So then I can perform ASIS compression, compressing there. Again, a positive test would be reproducing his pain, and I can also do this compression in side lying, where I go to the patient's ilium and apply an anterior compression force. And lastly, I can do a sacral thrust with the patient in prone and finding the PSIS and sacrum and thrusting down there. Again, looking for a reproduction in his pain. And like I said, if 2 out of the 4 tests are positive, then we can rule in the SI joint. This next test is called the supine active straight leg raise test. It's done for suspected SI joint instability. So I'm going to have the patient actively raise his leg, and if I notice any unfluent motion or if it's painful for him, then I can go in and compress at the pelvis, providing stability at that SI joint. And then I can have him raise his leg again, and if the control is better or the symptoms are less, then that's a positive test for form closure. So this can also be a force closure problem with the muscles. So I'm going to have the patient raise his leg and say that's painful for him. Then I can have him lift his trunk diagonal when he crosses his arms over his chest. And this will create a force closure when I apply a downward force at his arm by having the thoracolumbar fascia help with the muscle controlled there, indicating a positive test if his symptoms are less painful. This next test is called the prone active straight leg raise test, which also assesses for SI joint instability. So with the patient in prone, I'll have him lift up his leg, and if this reproduces any of his back or pelvis pain, then I can go in and stabilize at the pelvis and have him lift up his leg again while providing stability. And if it's less symptoms of pain or his form is better, then that's a positive test. We can also assess the thoracolumbar fascia through a force closure ability. I'm going to have him raise his leg. That's painful for him. Then I can have him raise his leg and his opposite arm, provide resistance, having the thoracolumbar fascia engage. And if that's less painful, then that's a positive test for force closure. The supine long sit test is a assessment done if there's suspected SI joint involvement. I'll have the patient bend his knees and I'll have him do a bridge pushing down through his feet, and then I'll stretch his legs out and have my thumbs at the medial malleoli, checking if one leg looks longer than the other. And then if the right medial malleolus is more inferior than the left, this would represent an apparent leg length difference with the right leg appearing longer. So I'll have the patient come into long sit and recheck this. If the right malleolus is now superior, then it is a right innominate rotated anteriorly. So in supine it looks longer, and in long sit it looks shorter. Vice versa, a posterior rotated right innominate would present with the right leg shorter in supine and longer upon sitting up. The next test is called the hip scour test, which is a screening tool to rule out the hip for general pathology. So with the patient in supine, I'll bring his hip and knee into flexion and take him into abduction and external rotation. And then I'm going to bring the hip into adduction and internal rotation and do this a few times, coming in and out of those positions. So a positive test here would be reproduction of the patient's complaints of pain. This next test, called the Patrick test or Faber test, is an assessment for intra-articular hip issues. So I'll have the patient cross his first leg over the other and have the knee drop. And I'm going to be looking at the distance from his knee to the table there. And then I'm going to ask him to do the same exact thing on the other knee, crossing his leg over his other leg, assessing the distance of the knee to the table, and if there's a greater difference of 4 centimeters between each leg, then that would indicate a intra-articular hip issue. Another test used to assess for hip pathology is the Fader test. So I'm going to bring the patient's hip into flexion, adduction, and internal rotation, and this position here will close down the joint, and I'm going to hold it here, and if this reproduces the patient's hip or groin pain, then that would indicate a positive test. This next test is the flexion adduction test, which is a test to assess for hip joint pathology, typically in a younger population. So I'll have the patient flex one hip and knee, and I'm looking to see if that leg can cross over his opposite hip, which it does, so that's a negative test. But if it doesn't cross over, then that would be a positive test. But we're going to compare it to the other side as well, have him do the same thing, looking to see if that leg crosses over the hip, which it does. This next test is called the log roll test, which helps identify hip pathology such as labral tears or impingements. So with the patient in supine, I'm going to passively move the patient's leg through the maximum range of internal and external rotation. A positive test would be popping or clicking sensation noted, which may indicate a labral tear, and then check the other extremity as well, because a positive test may also be an excessive range of motion compared to the other side. This next test is called the anterior labral tear test, which assesses for impingement, anterior labral tears, or iliopsoas tendinitis. So I'm going to bring the patient's hip into flexion, external rotation, and abduction, and then I'm going to slowly move it into internal rotation, adduction, and extension. So I can do it a few times, but it is positive if it reproduces the patient's symptoms or if pain is reproduced with or without a click. So this next test is called the posterior labral tear test, which is a test assessing for posterior hip impingement, posterior labral tears, and anterior hip instability. So I'm going to bring the patient's hip into flexion, internal rotation, and adduction, then slowly move it into external rotation, abduction, and extension. So a positive test would be if groin pain is experienced or reproduction of the patient's symptoms with or without a click. This next test is called the Craig test, which is used for assessing femoral anteversion or retroversion. So I'm going to palpate for the greater trochanter and passively rotate the patient's femur into internal and external rotation until I find where his greater trochanter is most prominent in my hand. So a normal femoral anteversion angle is 8 to 15 degrees. If it's past 15 degrees and excessive external rotation, it would be an excessive amount of anteversion, or less than 8 degrees would be more retroversion. So I'm going to ask the patient to hold his knee in that position, and I'm going to take my goniometer and have the stationary arm lined vertically and the moving arm going to line up with the tibia, and I'm going to calculate that angle, and it comes out to 9 degrees, which is a normal femoral anteversion angle. This next test is called the fulcrum test, which is done if we're suspecting a stress fracture in the patient's femur. So I'm going to put my forearm under the thigh that I'm assessing and fulcrum over by pushing down on his thigh, and a positive test would be reproduction of the patient's pain. The next test that I'm going to be demonstrating is the patellar pubic percussion test, which is a test that uses auscultation and percussion to screen for fractures at the head or neck of the femur. So I'm going to ask the patient to place the stethoscope over his pubic bone so that I can pull the skin back around the patella and percuss by tapping at the patella, and the sound produced at the uninvolved side is clear and crisp, indicating that there is no fracture at the proximal femur on this side. But say if I were to go assess the involved side, I'm going to have the patient do the same thing by placing the stethoscope over his pubic bone, pulling the skin back around the patella, and then percussing at the patella. The sound produced on this involved side is dull and muffled, indicating a proximal femur fracture. The next test I'm going to be demonstrating is Eli's test, which is a test for assessing rectus femoris tightness. So I'm going to passively flex the patient's knee and notice what happens at the pelvis. So on this side, it doesn't move upwards, indicating a negative test, but on his involved side, if we look at the pelvis when I flex the knee, his hip rises, indicating hip flexor tightness. Positive test. This next test is called the piriformis test, which is a lower limb provocation test to evaluate the impact of the piriformis muscle on the sciatic nerve, as well as detect tightness of that muscle. So with the patient inside lying, I'm going to flex both his hip and knee while stabilizing the pelvis and applying pressure to the lateral side of the knee. We're going to hold it here, and a positive test is if the patient complains about pain in his buttock area or radiating pain down the backside of his leg. The next test shown here is the Trendelenburg sign, the single leg stance test, which serves a purpose to identify weakness of the hip abductor, specifically glute med. So I'll have the patient stand in this position for 30 seconds while I'll observe his pelvis from different angles, because a positive test is an inability to keep the pelvis parallel to the ground, and this may be accompanied by a lean to compensate for the weak abductors, while a normal test is able to lift the leg and keep the pelvis level as the patient is doing so here. This next test is called the external derotation test, which is a test used for suspected hip pathology of the lateral muscles such as glute med or glute min. So I'm going to bring the patient's hip and knee into 90 degrees of flexion and then into some external rotation. So I'm going to stabilize the knee and give resistance on the outside of his heel while the patient brings his leg back to neutral. A positive test is a reproduction of the lateral hip pain. So the prone derotation test is done if I get a negative finding while doing the external derotation test in supine. So again, I'm going to start with his leg in external rotation and have the patient resist me back to neutral. Just like that. And a positive test will be a reproduction of that lateral hip pain. Next, I'm going to be demonstrating a joint mobilization known as hip distraction. So I'll grasp the patient's ankle above both malleoli, and I'm going to move him into the open pack position of slight flexion, abduction, and external rotation while leaning back with my weight to provide that long axis traction, and this is indicated for pain control and general mobility. So the next joint mobilization technique I'm performing is a lateral glide, which is indicated for pain control and general mobility. I'm using that towel so the belt isn't rubbing on the patient's skin directly. So I'm having him in supine, and I'm going to flex his hip and knee to about 90 degrees. The belt's around the proximal thigh of the patient and my waist, and I'm going to be supporting his thigh and pulling laterally through the belt by leaning back and the plane of the neck of the femur. This next mobilization is a posterior glide to increase flexion and internal rotation of the hip. So the patient is in supine with his leg off the table, the belt is around my shoulder and on his thigh. I'm using my mobilizing force through my hand in a posterior direction with my elbow extended, and I have the patient flexed at his knee and he's holding his opposite knee up on the table. This last joint mobilization technique is a hip anterior glide indicated to increase extension and external rotation. So the patient is positioned in prone with his lower extremities off the end of the table, and I'm applying my mobilizing force through my proximal hand in an anterior direction by flexing at the knees, and the belt is around my shoulder.